Associate Professor of Department of Pediatrics at Assam Medical College, and she is also a present Secretary of E-Zone Chapter of ISPN. Over to Dr. Arpita to introduce the speakers of the day.
Yeah, am I audible?
Yeah, you are audible.
Yeah. So at the outset, I thank the organizers and especially Dr. Kalaivani for giving me this opportunity to be here in this excellent educational initiative that has been undertaken under the aegis of the IPNA. I would like to welcome our first speaker for today, who is Dr. Jubaida Romana. She's an FCPS in pediatrics. She's an IPNA fellow in pediatric nephrology from the St. John's Medical College in 2014. Her current affiliations are she's an associate consultant at the Asghar Ali Hospital in the Department of Pediatrics and Pediatric Nephrology at Dhaka, Bangladesh. She has specific academic interest in the field of renal critical care and voiding dysfunction. Her accomplishments are she's the Cultural and Social Welfare Secretary in the Pediatric Nephrology Society of Bangladesh. She's the ex-associate editor of the Pediatric Nephrology Journal of Bangladesh. She has various publications in different reputed journals, and she has also had many presentations and papers in national and international scientific conferences. She'll be speaking today on the important topic of fusion anomalies of the kidney and the urinary tract. The upper urinary tract, as we know, has the distinction of being the most common human system which is affected by congenital anomalies. There's a wide spectrum which may range from innocuous and clinically insignificant to deformities which may lead to even end-stage renal disease. Hence, a proper understanding of their pathophysiology and etiogenesis is required for proper diagnosis and management. So I welcome Dr. Jubaida here on this forum, and it is over to you, Madam Jubaida.
Thank you, Doctor. Welcome you all. So I just share my slides first. Is this visible? Hello?
No. It's not visible, Jubaida.
Just a minute.
Probably, Jubaida, you're into two windows. If you have kept two windows open, then you would be clicking onto one window. Just scroll down and see, like which window is open.
Is it still two?
It's not visible.
Just a minute. I just leave and join again. Some internet issues were there. I just leave and join.
Yeah.
Where is the sharing screen?
Initially, you tried. Yeah. Can you put it in full screen?
Yeah, I'm doing it. Sorry for the technical issues. So, first of all, my heartfelt thanks to the organizer committee of this fourth IPNA endorsed webinar series for inviting me today, and my good friend Dr. Kalaivani for giving me the honor. So over the last few weeks, we are hearing different topics on CAKUT, and every day we are learning new things and updating our knowledge. So today I'm going to discuss on the fusion anomalies of the kidney and the urinary tract. So the renal fusion anomalies are a common congenital anomaly of the kidney and urinary tract, and mainly is the upper urinary tract. And these anomalies occurs due to disruption of the normal embryological migration of the kidneys. Not only problem in the migration, it has also associated renal rotation problem and vascular supply. And these fusion anomalies are always associated with some congenital anomalies of other urogenital tract, gastrointestinal tract, cardiovascular system, skeletal system, and neurological system. So these CAKUT are not so less in the population. About 3 to 11% of the population are suffering from congenital anomalies of kidney and urinary tract, and it's almost 50% of all congenital anomaly. So why this embryonic defect occurs? There are some sporadic cause, some environmental, and some genetic cause. So if any insult occur in intrauterine life, it can cause congenital anomalies. So the risk factors are maternal diabetes, hyperglycemia, some offending drugs like glucocorticoid, then anti-epileptic drugs, cyclophosphamide, MMF. If the patient mother have any history of taking alcohol or abuse, alcohol or drug abuse, so this all risk factor can cause congenital anomalies of the kidney and urinary tract. So these CAKUT are divided in according to the pathogenesis. So the most common is the dilatational defect. It could be non-obstructive and it could be obstructive. Sometimes there are defect in number, sometimes in size, and also sometimes there is dysplasia. My next speaker will discuss on those topics. And today my topic is on the positional defect, some like horseshoe-shaped kidney, ectopia, and malrotation. So before going to my main presentation, I just memorize the development of the kidney. So we all know that kidneys are retroperitoneal organ and it is bean-shaped. It lies over the thoracic 12 to lumbar 2 vertebra. And very early period of the gestation, this renal development occur. At the 4th week of development, this from the urogenital ridge are formed, and it's from the intermediate mesoderm. And these nephrogenic cord are divided initially in 3 early kidneys like pronephros, mesonephros, and metanephros. Within the 25 days of gestation, these pronephros are regressed, and the mesonephros are formed, and it forms some external tubules. And this mesonephros goes downwards and form with the mesonephric towards the cloaca, and with the cloaca, it formed the metanephric blastema. And important protein-like secretion are formed for the lateral growth of the ureteric bud. This all process occurs around 4th to 5th week. And after that, from the metanephric blastema, the main male genital organs like epididymis, vas deferens, seminal vesicles, and the part of kidney, the nephrons are formed. And later, from the ureteric bud, the collecting tubules are formed. The bifurcation starts from the beginning of 6th weeks, and initially in first bifurcation, the renal pelvis are formed, and after that, from 6 to up to 32 weeks, in different process, this major calyx, minor calyx, all are formed. And in this period, from the 6 to 9 weeks, kidneys ascent upwards is occurring, and as the gestational advances, the lumbosacral growth causes these kidneys to relatively ascend in its final position that's near to the suprarenal organ. And in this period, the kidneys get their vascular supply from the dorsal aorta and its neighboring branches and accessory renal arteries. So also in this process, there are some kidneys rotation occur, and kidney rotates 90 degree, and the renal pelvis are directed anteromedially. So why this renal fusion anomalies occurs? There are some theories behind this. The most acceptable theory is the arterial fork theory. Here, the umbilical arteries work as a arterial fork, and it causes the apposition of the developing metanephric blastema. Second theory is the abnormal caudal flexion and rotation theory. We know that these fusion anomalies could be symmetrical or asymmetrical. The symmetrical fusion anomalies results from abnormal ventral flexion of the caudal fetus, and asymmetrical fusion anomalies affect both kidneys, such as lateral flexion and rotation of the caudal fetus. So the associated anomalies of the spine and other pelvic organ supports this theory. Third theory is about abnormal ureteral development. When there is abnormal converging course of the ureteric buds, that forces the metanephric blastema to fuse. And fourthly, abnormal metanephric migration. There is some teratogenic effect in the developing kidney, the parenchymal part. So abnormal migration of the metanephric cell across the primitive stick, resulting this fusion anomaly. And this fusion anomaly, we see they are sometimes associated with chromosomal abnormalities, familial clustering, and male preponderance. So these are also support. There is some association with the genetic association. So for diagnosing the CAKUT, firstly, we get the information from the prenatal ultrasonogram. At very early period, about 9 to 12 weeks, we can demonstrate the fetal kidney, and the corticomedullary differentiation can be demonstrated around 15 weeks. So this antenatal ultrasonogram is very important to detect major renal anomalies, though it is limited to the operator and patient dependence. So by this antenatal ultrasonogram, in very early period, we can evaluate the renal presence, location, size, echogenicity, and any fusion of the kidneys. And also we can get information from this ultrasound about the urinary bladder, external genitalia, and amniotic fluid status. So if there is amniotic fluid level is normal and the renal fossa is empty, there is much probability of renal ectopic CAKUT is more. So we divide the renal fusion anomaly in two broad headings. Sometimes they can present separately, or sometimes they were together. Like if the fusion anomalies are is also in the abnormal position, so they are like cross-fused renal ectopy, where both the ectopic kidney is just cross the midline and fuse in the inferior pole of the normal kidney. But in simple ectopy and cross ectopy, there is no fusion. In simple ectopy, only the kidneys are slightly downwards in its orthotopic position. And in crossed ectopy, there the one kidney is goes towards opposite side, but these both kidney are not fused. And in horseshoe and pancake kidney, we saw that both the kidney are fused and it's slightly lower than its normal position. So I just share one case from my OPD. So this is a 9-year-old male child came to OPD with occasional abdominal pain, and the pain is sometimes so severe that the child often misses his daily school. So this pain has no association with any food intake, and sometimes the patient having history of constipation. So as a routine investigation, ultrasonogram of whole abdomen was performed, and we see there is a fusion of both kidney. This star is marking as the isthmus. So for further diagnosis, we counseled the parents and did a contrast-induced CT scan, and it showed midline fusion of the both kidneys in the lower pole through an parenchymal isthmus, and there is no other renal abnormality. So this patient was diagnosed as horseshoe-shaped kidney, and the child is on follow-up. So horseshoe kidney is the most common fusion anomaly, around 90% of the all fusion anomalies. The incidence is 1 in 400 to 600 live birth, and male are more commonly affected, around twice of the female. Here, the inferior pole of both kidney usually directed medially and fuse across the midline. This portion is isthmus. This could be renal parenchymal fusion, or sometimes it's a fibrous tissue portion. So at the fourth week of development, when the renal flexion, renal rotation is started, and the renal ascent are occurred, at that time, if there is any abnormality or like the metanephric blastema are in close apposed position, and if there is absence of renal capsule, the both kidney are joined together and form the isthmus. And the internal mesenteric artery here works as an arterial fork, and it prevents the ascent of the horseshoe-shaped kidney further ahead. So this isthmus located anterior to the aorta and IVC and prevents kidney's normal ascent and normal rotation. And here, ureters usually shows an abnormally high union with renal pelvis. So according to the fusion of the horseshoe-shaped kidney, the horseshoe-shaped kidney are divided in 6 major types. So here in the first picture, I'm just showing the fusions. So here it's first is parenchymal isthmus we are seeing, and second is it's a fibrous isthmus. So sometimes also the superior pole of the both kidneys are joined and it forms the disc kidney. And the superior pole are joined and it's like inverted U shape. Very rarely, one kidney's inferior pole and other kidney's superior pole may be connected and it forms the isthmus. In this picture, there is the lateral fusion. Here, the fusion is slightly medial to the slightly lateral to the midline. Also, one classification was there. It's according to the vascular supply. There are type 1, type 2, and type 3. So in type 1, there is all the renal arteries are normal in position. There are no ectopic arteries. In type 2, there are some renal ectopic arteries, and type 3, all the arteries are ectopic in position. This classification is important for the surgical correction of the kidneys. So most of the case, the horseshoe-shaped kidney patients come to us asymptomatic. Incidentally, we diagnose the case, but when there is some association like ureteropelvic junction obstruction, renal stone, or vesico-ureteric reflux, this patient can present with urinary tract infection, and as well as they come to us with pain, hematuria, and UTI-like features. And the renal stones are common around 20 to 60% in case of horseshoe-shaped kidney due to the urinary stasis, increased risk of infection, and there are some metabolic abnormalities like hypercalcemia, hyperoxaluria, hyperuricisuria, and hypocytruria. Horseshoe kidney are also associated with syndromic features like Turner syndrome, Down syndrome, Patau syndrome, and Edwards syndrome. And there is also chance of renal carcinoma in case of horseshoe-shaped kidney. Most common is the renal cell carcinoma, then transitional cell carcinoma and Wilms tumor and carcinoid tumor are also seen. So here in one study, it was done in 2015, they have taken 50 patients of horseshoe-shaped kidney. Among them, male patients were 31 and female were 19. The age limit was from 1 day to 12 years. They were followed for around 4 years, and this patient have other urological anomalies like ureteropelvic junction obstruction in 12 cases, primary viewer in 13 cases, and ectopic ureter in 1 patient. Among these 26 patients, 15 patients required in surgical correction over the follow-up period. So there are also these horseshoe kidney are also associated with extrarenal syndrome, like gastrointestinal anomaly, like as club foot, scoliosis, vertebral abnormality, and rib abnormality. Sometimes GI anomaly like anorectal malformation, Meckel's diverticulum are also there. And I also mentioned that Turner syndrome and other syndromic features are associated. So here in an article, they taken 380 children of horseshoe kidney, and their median age was 2.8 years. They were followed for 24 years. Among these 380 patients, 175 patients had associated other renal anomalies, and about 190 patients, near about 50% cases, they have other systemic involvement, like GI system, 60 in number is 62, vertebral in 54, and Turner syndrome patient were 16. And these horseshoe-shaped kidney patients are also vulnerable to trauma due to its lower or more anterior position and lack of protection by the rib cage. Also, midline isthmus is particularly vulnerable to compression injury as it stays against the spine. So for evaluating the horseshoe-shaped kidney, ultrasonogram is a very important tool, and it can locate the isthmus and its position, and it can say the all maximum information can give us. But in plain radiography, we also show medially placed lower pole of the both kidneys, which converge towards the spine. And if we do IVO, which is nowadays it's not so not commonly done, it can demonstrate that medially rotated lower pole of the calyx facing the spine, like it's hand holding calyx. And ureters curve laterally as they cross the isthmus and appearance like flower bus appearance. Just in the picture, we are seeing the flower bus appearance. So CT and MRI also we can perform, and it can give us the conclusive idea about the horseshoe-shaped kidney, and it can demonstrate the renal parenchyma, vascular or supply, and other urological anomalies, and it can differentiate the function and isthmus from fibrous tissue. Sorry, I'm actually suffering from flu, so for management of the horseshoe-shaped kidney, the main important thing is the follow-up, because when the horseshoe-shaped kidney are associated with other extrarenal manifestation or other urogenital problem, the child should be kept in follow-up routinely. So here in these two studies, one is from the children's side and other is from the adult side. So in the first study, they have taken 41 children of horseshoe kidney, and they are from the 2 months to 16 years of age. Total 10 years they are followed up, and around this 41 patients, 7 patients required surgical intervention like pyeloplasty, ureteroneocystostomy, and upper pole heminephrectomy. And over this 10 years of time, they have in 10 patients, the renal scar are found. Some on 6 patients, proteinuria was there, and among the 6 patients, 4 patients had hypertension. And among this 41 patients, 3 patients developed chronic kidney disease. And in the adult study, they have taken 146 of horseshoe kidney, and they are mostly their age limit was more than 20 years. It's a case control study and followed for 9 years. They have found the chance of obstruction, kidney stone, UTI, and urogenital cancer are more in horseshoe-shaped group. And the incidence of end-stage renal disease are 2.6 to 10,000% per year, which is slightly higher than the non-horseshoe-shaped kidney group. The second fusion anomaly is the pancake kidney, lump kidney. There is the complete renal fusion of the superior middle and the inferior pole of both kidneys, and it lies in the pelvic cavity. This is rarest among the incidence rate is 1 in 6, around 65,000, but it is common in male sex. Each kidney has its own excretory system, and 2 ureters do not cross the midline and insert it into the bladder. Rarely, this pelvic kidney can have 1 ureter. They are also associated with vertebral and genitourinary anomalies, and developmentally, when the umbilical arteries press the nephrogenic primordia and the kidneys, these fuse in the pelvis and it do not ascend. And this pancake kidney have some primitive renal vasculature from the single artery arising from the distal or iliac arteries, and it drains into the inferior vena cava or iliac veins. For evaluating this case, they have no symptoms usually, but they are prone to develop UTI and renal stone. And if we do the ultrasonogram of this patient, we found absence of the kidney in the renal fossa, and there is ectopic location in the pelvic cavity, and there is extensive medial fusion. They have separate pelvic-calyceal system, and renal pelvis are anteriorly placed, and short ureters enters normally in the urinary bladder. This causes repeated urinary tract infection. And if we do the CT and MR urography, we can confirm the diagnosis, evaluate the vasculature and complication, and if there are any other abnormalities, this is clear by CT angiography. Next is the renal ectopy or ectopic kidney. This is due to the abnormal position of the kidney, occurs when kidney fails to ascend to its normal position and during the embryological development of 6 to 9 weeks. So according to the position of the ectopic kidney, these are divided into simple renal ectopy, cross renal ectopy without fusion, cross renal ectopy with solitary kidney, and bilateral cross renal ectopy. Also, these renal ectopic ranges are 2 to 10 per 10,000, and depending on its mode of detection, like antenatally or postnatally or during autopsy. So simple renal ectopia mostly located in the pelvis, but it can present also in iliac region, abdomen, as well as chest. Though pelvic kidney is the most commonest of the simple renal ectopia, that is 1 in 2,200, and 10% cases, these are bilateral. But due to the ascent problem, there are sometimes the kidneys are in iliac, even in the thorax. So normally, naturally, when the kidney ascends, liver act as a barrier, and the early fusion of the pleuroperitoneal membrane can also prevent the further ascent. But if there is any problem in the adrenal and liver group, then this renal ectopy can occur. And so, very rarely the thoracic ectopy is occur. It's very rare, like 5% of all renal ectopic cases. But when the patient are present with thoracic ectopy, they have subdiaphragmatic hernia with and now the blood supply we get from this iliac and infrarenal aorta, and all sometimes at the hypogastric and median sacral artery. And renal ectopic patients are also asymptomatic. So here, usually we diagnose from the antenatal period. So in this article, they have taken 40 number of the patient who have empty renal fossa. And among these 40 patients, renal ectopy were present in 25 cases, 24 were simple, and 1 is crossed. And 2 patients have horseshoe-shaped kidney, and 13 patients have renal agenesis. But as the renal ectopy has defect in malrotation and anteriorly placed renal pelvis, these patients are prone to develop hydronephrosis. So for the hydronephrosis, the patient have chance of developing UTI, urinary obstruction, and kidney stone. So the patient came to us with features like pain, fever, hematuria, and sometimes incontinence due to simple small renal ectopy or the ectopic ureter. And also the ureter can be inserted into the urethra, so this patient can have incontinence. And if we palpate the abdomen, sometimes the ectopic kidney we can palpate, and other findings, it's hypertension. They are prone to develop hypertension. They are also very prone to traumatic injury because of their abnormal location in the retroperitoneum. So in renal ectopy, the most commonest associated condition is vesico-uretary reflux. Among 1/3 of the patients suffer from VUR, and this is higher in the simple renal ectopia. Also, ureteropelvic junction obstruction are associated, and it is more common in cross-fused renal ectopy in compared to renal ectopy. Sometimes renal dysplasia are also there. And some genital anomalies, like in case of male hypospadiasis, cryptochordism, in female agenesis of the uterus and vagina, and uterus abnormality like unicornicoid, bicornicoid, or septate uterus can be present. And non-genital abnormalities like adrenal, cardiac, and skeletal anomalies. And I already mentioned thoracic kidneys are often associated with subdiaphragmatic hernia. So evaluation part, we from if there is any anomaly by the physical examination, we can detect it. And imaging, bioimaging has an important role, like antenatal imaging, postnatal ultrasonogram. We can do and find the renal ectopy and position of those. And vesicocystourethrogram is also we can do if there is VUR, but it is not indicated in all cases. When there is the patient having UTI or hydronephrosis, vesicocystourethrogram can be done. DMSA has also an important role. If the kidneys, we are not finding the kidney, where is the kidney in the ultrasonogram, DMSA can detect the functional tissues. And by this, the renal parenchyma and differential assessment of the kidney function we can detect. Also, if there is severe hydronephrosis, DTPA or like diuretic nephrogram and MAC3 can give us information. And CT scan is the most conclusive investigation. It can give the detailed anatomy and vascular anatomy of the kidneys. So in the management part, these patients are also need to be in follow-up, and if there is any surgical emergency, the surgical correction is needed. And in 41, this is an article where the renal ectopic patient are followed up. In 41 patient, those have the age limit was age was 0.2 years mean age, and they were followed for 7.7 years. So they found by 7.7, like around 8 years after following them, there is no evidence of albuminuria, no hypertension. Only 9 children developed GFR less than 90. So another case study from my OPD. This is a 9-month-old boy came to OPD with an ultrasonogram report, which was performed outside, which showed non-visualized right kidney. The baby had history of repeated excessive cry and repeated fever. So, and also the child was constipated. So I see the patient having some eye abnormality. There is a nasal deviation of the left eye. So for this complaint, they have performed ultrasonogram outside, and as the kidneys are not in the exact position, so the patient was referred to us. So firstly, we did a repeat ultrasonogram, and it showed cross-fused ectopic kidney. And there, if you see the picture, the right kidney is fused with the left kidney here. And although we are seeing that the CMD is maintained and ureters are not dilated. So after counseling the parents, we did contrast-induced CT scan, and it showed that right kidney is not in the normal position. It crossed the midline and fused with the contralateral left kidney, slightly lower down in position. But the kidney have normal nephrogram with preserved CMD in the both kidney. So we diagnosed the patient as cross-fused renal ectopy, and we counsel the parents, and the child is kept in follow-up. Initially, there is no renal functional anomaly. We didn't find any features of UTI. And to find out other anomalies, we did echocardiogram. It showed that patent foramen ovale, and ophthalmological consultation was taken, and they said the child have left estropia with refractive error. The child is still in my follow-up, and after 1 year, we did another ultrasonogram. And the boy kidney is left kidney is going well, and still the CMD is maintained. So this cross-fused renal ectopy is a type of partial fusion anomaly, which characterized by presence of an ectopic kidney that crosses the midline and fuses with the orthotopic contralateral kidney. Despite ectopic renal position of the kidney, ureter of an ectopic kidney has normal insertion in the bladder. This is the main difference from the pancake kidney with this cross-fused kidney. The incidence is second most common fusion anomalies, and the incidence is 1 in 1,300 to 1 in 7,500. Here also male are more commonly affected. And among all the cross-fused kidney, inferior ectopia is the commonest. So why this renal fusion anomaly occurs? There are two theories. So there is abnormal migration of the ureteric button and the metanephric blastema. So theories behind it: the abnormal position of the umbilical artery, which influences the cephalic migration of the kidney, which follows in the path less resistant and migrates to the contralateral side. And another theory is ureteric bud that crosses over because of overbending and rotation of the caudal lint of the embryo and preventing the fusion of the ureteric bud with the metanephric blastema. So there is a stimulation of the contralateral metanephric blastema while the ipsilateral metanephros are regress. So according to the position of the fusion, the cross-fused kidney are divided into 6 varieties. So this is the inferior cross fusion. It is the most commonest. There, the normal kidney is fused with the ectopic kidney. And the S-shaped kidney, there 2 kidneys are fused, but the position of the kidney is opposite, like the renal pelvis. The normal kidney position is in the medial side, and the ectopic kidneys, renal pelvis is directed on the lateral side. So lump kidney, both kidneys are fused in a wide axis, and it's usually present slightly lower than the normal position. Also, sometimes the ectopic kidney can be present transversely, like it's formed L shape, and it's joined in the inferior pole of the normal kidney. And there is a midline fusion of the both kidney. And if you see that the ectopic kidney's ureter are cross the midline and it's inserted in its normal orthotopical position. And sometimes the ectopic kidney can be superior to the normal kidney and fused in the inferior pole and normal kidney's upper pole. So also these cross-fused renal ectopy patients are asymptomatic. Incidentally, they are diagnosed. And if there is any other associated anomalies like hydronephrosis, vesicoureteric reflux, nephrolithiasis, the patient can come with some symptoms like pain, hematuria, and UTI-like features. And they are also associated with other skeletal, genital, anorectal, and cardiovascular system anomalies. So for evaluating, ultrasonogram is the first and very important tool. We can find here that the absence of kidney on the ectopic location and in the contralateral lumbar or iliac region. Fusion is identified by the presence of anterior and posterior notches, and it can result in elongated renal mass that can be seen in the ultrasonogram. And if we do the intravenous urography that demonstrate ectopic location and fusion of the affected kidney in the contralateral side with ureter crossing the midline and insert into the bladder orthotopically. The picture is showing very clearly. And if we do the CT and MR angiography, we can detect the abnormal position of kidney, allows earlier identification of the vasculature and details of the collecting system. Last but not the least, renal malrotation. This is also an abnormal position of the kidneys in relation to the hilum, and it could be unilateral or bilateral. Usually, these renal malrotation are associated with other renal anomalies, mostly renal ectopy. They are also common in male in 1 in 2000 autopsies. And most of the cases, renal malrotation patients are asymptomatic, and also with the other urinary problem, they present with us some symptoms. Embryologically, when the ureteric bud inserts into an abnormal region of the metanephric blastema, usually renal malrotation occurs. And because of its association with renal ectopia, the process of ascent and rotation probably related for renal malrotation. So according to the malrotation, they are also divided into 4 important types. Mostly in the normal kidney, the kidneys, hilum and the pelvis are located anteriorly or medially. But in non-rotation, which is the more commonest renal malrotation, here we see the renal pelvis and hilum of the kidney are located laterally, slightly laterally or in between the anterior medially. And ureters are moving, renal vasculature are moving to the laterally. In reverse rotation, the renal pelvis and hilum is in the lateral position and the renal vessels cross anteriorly and anteriorly it goes. And hyperrotation, there is the rotation more than 180 degree but less than 360 degree, and the renal vasculature are going posteriorly. Sagittal rotation is very less common, and there is a rotation around the sagittal plane. So for evaluating this renal malrotation, we can find it incidentally with ultrasonogram and CT MRI, and sometimes this patient present with us to abdominal pain and other urinary abnormality. So in conclusion, though the renal fusion anomaly are not so common and asymptomatic and has immense clinical importance because of their other concomitant congenital anomalies and involving the other organ system. Knowledge of this complex imaging anatomy of the fusion anomalies and their associated anomalies help us to planning appropriate therapy. Thank you.
Thank you so much, Dr. Zubeda, for your excellent and comprehensive presentation on fusion anomalies of the kidney and the urinary tract. We thank you for joining us all the way from Bangladesh. And we will move on to the next topic now. And I request the viewers to put in their questions in the question box, question and answer box. We will be taking all the questions for both the sessions together at the end. Our next topic for today is being presented by our next speaker, Dr. Alpana Ohri. Madam is additional professor of pediatrics at the Bhai Jerbai Wadia Hospital for Children in Mumbai. She's in charge of the Division of Pediatric Nephrology there. She's also a consultant pediatric nephrologist at Jaslok Hospital, Mumbai. She has a specific clinical interest in the field of critical care nephrology, dialysis, and clinical nephrology. She has had a distinguished academic career. She had been the best graduate in her MBBS, and she was a gold medalist in DNB pediatrics at the All India level. I welcome Alpana Madam to present her talk on the topic of understanding renal agenesis and dysgenesis. Madam, it's over to you. Madam, you'll need to unmute. Yeah, thanks.
Good evening, everyone. Thank you, Dr. Kalaivani and Dr. Nammalwar for giving me the opportunity to speak on such esteemed forum. And I would upfront acknowledge that I am a hardcore clinician. So although this is kind of a theoretical topic, but I cannot refrain from being myself. So, and I also think that already a lot of speakers have done a lot of justice to a similar topic, talking about genes and kidney development and so on. So I would touch these topics briefly, but I would be specifically talking about the clinical bit more. So understanding agenesis and dysgenesis. I hope my slides are visible.
Yes. Yes, ma'am.
Are the slides visible?
Yes, it is visible.
Okay. So I would begin my talk on understanding agenesis and dysgenesis. It seems to be a little.
Oh, Dr. Alpana, can you please unmute yourself?
Are they visible now? My slides?
Slides are visible. In between, you had muted your.
Yeah. Okay, okay. So, it's stuck.
It is seen in full screen. You just have to move your slides.
I'm not being able to go to the next slide. So,
it is moving.
Yeah. No. Yeah. Okay. So, beginning with the embryology, we know that kidney derives its origin in the metanephros. The differentiation of the primitive kidney is stimulated by penetration of the metanephros by the ureteric bud, which happens by about 5th week of gestation. By 10th week, the division of the ureteric bud within the metanephros induces the development of nephrons. Essentially, we have to understand that it's the metanephric blastine which forms the glomeruli and the tubules, and it is the ureteric bud which gives rise to intrarenal collecting system, in addition to calyces, renal pelvis, and the ureter. So all this happens by about 15th week, and by 20th to 26th week, the nephronogenesis starts, and it is most active in that phase. By 36 weeks, nephrogenesis is complete, and this is the time at whichever number of nephrons are present or developed at this point of time is the nephron endowment for life. Now, going on to renal malformations. Renal malformations associated with reduced renal functioning mass are responsible for about 20% cases of end-stage renal disease. And with lower urinary tract anomalies are called CAKUT. According to gross morphology and histology, the renal malformations associated with reduced functioning mass can be categorized into agenesis or aplasia and dysgenesis. Agenesis refers to complete absence of kidneys, and dysgenesis refers to maldevelopment of kidneys in terms of size, shape, or structure. Dysgenesis further can be classified into dysplasia or hypoplasia. Dysplasia is defined histologically by presence of malformed renal tissue elements, primitive tubules, interstitial fibrosis, cartilage in the renal parenchyma, and hypoplasia by congenitally small kidneys with reduced number of nephrons but with normal architecture. So going on a little further about each condition, renal hypoplasia, as I mentioned earlier, it refers to a small kidney which contains intact nephrons that are reduced in number, and it is diagnosed histologically by reduced renal mass having less number of nephrons with but the per mass of the tissue, the total renal mass itself is reduced, but and so the number of nephrons is reduced. There is no evidence of dysplasia here, and there are no cysts. Sonographically, it is seen as symmetrical reniform kidneys with size less than -2 SDs for mean age. And with, if it is diagnosed in the antenatal period, there may be associated oligohydramnios if renal hypoplasia is severe. Other tests used for diagnosis of renal hypoplasia are the radionuclide test. They help in ruling out scarring as a cause of renal hypoplasia. When a patient is coming for the first time with smallish kidneys, we cannot distinguish upfront whether it's hypoplastic kidneys or a scarred kidneys. So radionuclide tests to rule out scarring. And radionuclide tests are a must in case of unilateral hypoplasia. The etiology of renal hypoplasia may be mutations in genes influencing ureteric budding, fetal urinary tract obstruction, or environmental influences such as VUR. In many, it is a genetic syndrome, which may occur in isolation or as a familial disorder. Now, as I said upfront, by definition, renal hypoplasia requires histology. Renal dysplasia refers to abnormal differentiation or organization of cells in the tissue. And sonographically, if you go, it is characterized by variably sized kidneys with loss of CMD with or without cysts. It is one of the most common cause of childhood ESRD and reported in up to 0.1 to 0.3% live births. The hypothesis for renal dysplasia is error of the inductive interaction between the ureteric bud and the metanephric blasteme. Renal dysplasia is often associated with genetic syndromes or may occur in isolation as a familial disorder. However, up to 30 to 50% of all those with unilateral dysplasia have contralateral urinary abnormalities. The incidence of unilateral dysplasia is about 1 in 1,000 and of bilateral 1 in 5,000. Unilateral dysplasia obviously has better postnatal prognosis than the bilateral one. And the symptoms are variable and range from symptomatic unilateral disease, focal dysplasia to progressive renal dysfunction, which is seen with diffuse or bilateral dysplasia. Again, confirmation of renal dysplasia mandates histology. Now, this is the era where we are not doing autopsies with the grace of God. So we don't have the entire kidneys at our disposal to kind of check the morphology in detail. And we don't even do biopsies in children who are having shrunken small kidneys less than 2 standard deviations, which by definition is seen in most of the cases of renal malformations associated with poor renal mass. So we can't really go back to histology, which is what is recommended. This is the age of imaging, especially sonography and genomics. So, and what probably because of this, the most of the recent publications, they kind of put together hypoplasia and dysplasia together as the terminology of hypodysplasia. They do acknowledge that certain conditions are definitely dysplastic, like MCDK. Certain conditions are definitely hypoplastic, like oligomeganephronia. But most often, what we see is hypodysplasia, and that is how we will be discussing. So in my talk, which I'm covering, I would be talking about genetics of renal parenchymal malformations associated with reduced mass, ultrasound in nephrology, renal agenesis, MCDK, which is the prototype of the renal dysplasia, hypodysplasia spectrum, and why it's useful to consider it as a spectrum, associations of the spectrum, prognosis, and management. I would also be talking about a few types of isolated renal hypoplasia, like renal coloboma syndrome, Ask-Upmark kidney, and renal tubular dysgenesis. And then I would be coming up to another topic, which is a surprise. Okay, so how do genes regulate the development? We have heard on this topic multiple times, but I would just go through it very briefly. Now, genes are responsible at all the steps in the renal development. They may prime some of the progenitors for nephrogenesis. They are responsible for transforming cells into nephric ducts. They govern arborization. They govern induction of adjacent nephron progenitors and transform them into nephrons. So aberrations in any of these can potentially jeopardize the normal development and lead to malformations. Now, in case of agenesis, it's mostly the lack of induction of metanephric blasteme by the ureteric bud. Whereas in the two kinds of dysgenesis, it is slightly more distal. In hypoplasia, it's a developmental arrest of the metanephric blasteme. And in dysplasia, error of the inductive interaction between the ureteric bud and the metanephric blasteme. The second topic, which I have stressed earlier, we must know a lot about is sonography, because we are not relying on histology to differentiate the various kinds of dysgenesis. We are relying on sonography. So here we know that in general, kidneys on sonography are seen as echogenic reniform masses in containing hypoechoic renal pyramids in the renal fossa. So this is what adult kidney looks like on sonography, with the length of about 10 to 12 centimeter, with the width of 4 to 6 centimeter, and parenchymal thickness of 13 to 25 millimeter. And we can appreciate that the echogenicity is slightly, as compared to liver, it is slightly less echogenic. And further, the pyramids are more hypoechoic than the cortex. Now, this is what the adult kidney looks like. Now, going on to the children, pediatric kidney diseases. In children, when the sonologist is doing sonography, it's not sufficient to just look at the kidneys. They have to measure the kidney size and check if it's appropriate for the age or not. And if they do not find the kidney in the right place, they have to look for a rudimentary organ or look at ectopic sites where kidneys may be present. And when they are done with, they also need to look at the urinary tract, genital tract for associated abnormalities. Now, when we come to newborn sonography, there is one additional layer of complexity. The newborn kidney, the cortex is more echogenic, as can be appreciated, than the normal children, the normal bigger children. And this increased cortical echogenicity is something which is physiological, which gets corrected after a few months. In the fetal kidneys, this is antenatal sonography picture. Here, the kidneys are visualized by about 10 to 12 weeks, seen clearly by about 16 weeks. CMD is appreciable by about 20 to 25 weeks. And here we have to use separate nomograms, which are not depicted, but which have to be followed for renal length at different gestational ages. Now, for those who do not have access to this nomograms, because they're slightly trickier to find, we can use this formula that the length of the kidneys in millimeters is approximately equal to the gestational age in weeks. In antenatal sonographies, we have additional parameter, which is Leica, which can be used to diagnose as a surrogate marker of severe renal malformations in the fetus. Now, Leica is produced at different ages in different amounts. But what is important to understand is that the contribution to the Leica by the fetal urine is significant after 16 weeks of gestation. So if we are talking about oligohydramnios, and we are implicating kidneys as the main culprit for causing oligohydramnios, this will be appreciated only after 16 weeks of gestation. Prior to that, it is not produced dominantly by the fetal urine. Now, we do not say Leica in absolute volumes. We talk in terms of AFIs. And we know that they are measured in 4 quadrants, and roughly per quadrant 2 centimeter is the limit. And for 4 quarters, 8 centimeter is, and actually, if we have to be very, very particular, we again have to use nomograms even for AFI. And oligohydramnios will be defined as AFI less than 2.5 percentile for gestational age. Going to the topic proper, the most important and the most devastating of all the malformations is renal agenesis. Renal agenesis refers to complete absence of one or both kidneys without identifiable rudimentary tissue. It is associated with agenesis of ipsilateral ureter, and the pathogenesis is failure of formation of the metanephros. There is causal heterogeneity. It may be due to failure of ureteric bud formation, failure of the bud to reach the metanephric blasteme, or failure of the bud to engage or induce the metanephric blasteme. All true renal agenesis arise due to this developmental aberration, but interruption in vascular supply may also be a phenomena. And a few cases where we are assuming that the kidneys are not present and they are renal agenesis, actually maybe not true renal agenesis, but maybe regression of a multicystic kidney, which may happen in utero as well. So whenever we do not find the kidneys in their rightful place in the antenatal scan, I mean, the sonologists find that, they corroborate it with lack of Leica, which is often anhydramnios. They counter-check their findings by doing a Doppler, which shows absence of renal blood flow. Unilateral, first going on to unilateral renal agenesis, it is fairly common, occurs in 1 in 2000, slightly more common in males, slightly more common on the left side, and it is very often associated with malformations of other organs. 30 to 70% cases have these associations. So there may be anomalies of the urinary tract, which may be VUR, which is the most common associated anomaly, or megaureter, PUJ, uretrocele, and even PUV. Besides the urological malformations, other malformations may be seen in the ear, genital tract, and axial skeleton. These are the 3 most common other organs which are involved with the renal malformations. And in the reproductive tract, the girls may have a bifid uterus or bifid vagina, and boys may have cryptorchidism or absence of vas deferens. And when certain types of these malformations are present together, they may fit into a phenotype of these particular syndromes also. Besides this, even cardiovascular, GI, and CNS malformations are known, and a lot of syndromes have been described with renal agenesis and all these malformations. Diagnosis, as we've discussed already, is absence of kidney, supported by, in unilateral renal agenesis, it is supported by compensatory hypertrophy of the opposite kidney. And whenever we are saying that there's no kidney present, we have to exclude the possibility of an ectopic kidney, and we have to corroborate our diagnosis with the renal Doppler, which shows no flow in the renal artery. Postnatally, if such a condition is diagnosed, we must again do DMSA to rule out ectopic kidney and to look at the status of the opposite kidney. Most of the patients with unilateral renal agenesis maintain GFR close to normal in their pediatric age group, and they have stable renal functions for decades. But it has been realized recently that up to 30% can progress to end-stage renal disease by 30 years of age. Why this happens? It can be multifactorial. There may be dysplasia in the remaining kidney, or due to associated lower urinary tract anomalies, or less nephron deficit per se, leading to hyperfiltration and its associated complications. Even in pediatric age group, patients of unilateral renal agenesis are known to have microalbuminuria. 16% have hypertension, and up to 10% may have GFR less than 60. So going on to when does the compensatory hypertrophy happen? The compensatory hypertrophy in unilateral renal agenesis happens very early, as early as 20 weeks. So, and it has been also seen that if the babies in the contralateral kidney show the size of the other kidney to be more than 50th percentile, the chances of these children to progress to CKD on follow-up is very minimal. So the size of the opposite kidney has a lot of prognostic value and for a long-term outcome. So these children in general are followed by annual review for hypertension, proteinuria, and serum creatinine. Because this is a familial disorder with a lot of genetic overlay, it has a familial distribution. Up to 15% of first-degree relatives of a patient having unilateral renal agenesis will have either a renal or a urinary tract malformation. So whenever a patient is diagnosed with unilateral renal agenesis, we must do renal sonography of the first degree relatives of the proband. So in general, although there were a lot of things about these children not being allowed contact sports and all, but there is no restriction in participation in normal sports. Only collision or full contact sports can be avoided. This is just an example of a lady who's done very well in athletics, and she was found to have single kidney when incidentally she had done a sonography for some health checkup. So sorry about this very horrific picture which I put down. This is in the era when autopsy studies were done. So we could visually see that the kidneys are absent, the renal fossas are empty. Here, I would just like to draw your attention towards these arrows. These are actually the adrenals, which can be seen very prominently in the absence of the kidneys. So bilateral renal agenesis is a rare entity, 1 in 4,000. And diagnosis again is non-visualization of fetal kidneys and ureter by 16th week of gestation. And characteristically, the sign is called the lying adrenal sign on sonography. There is oligohydramnios or anhydramnios, which is seen in bilateral renal agenesis beyond 16 weeks. And again, there'll be no flow in the Doppler. Most cases are sporadic. Rarely monogenic causes have been associated, showing autosomal recessive, X-linked, and even autosomal dominant inheritance. There has been some association that mothers who are having diabetes are more prone to have bilateral renal agenesis, children having this problem. And even the ones who are smoking or binge drinking may have higher chances of bilateral renal agenesis in their children. Most cases of bilateral renal agenesis, almost 30 to 40%, they have in utero demise. And the ones who are born, they often have Porter's sequence and die within a few hours. And they have a characteristic facial profile of Porter's facies with limb deformities, IUGR, decreased fetal movements, joint contractures, and may even have known to have a breech presentation more commonly. There has been some literature on use of amnioinfusion in patients of bilateral renal agenesis, both for diagnostic purposes and in an attempt to salvage the child, unborn child. People have said that giving the diagnosis, antenatal diagnosis of bilateral renal agenesis is very ominous, And when there is no liquor, they can't even visualize the kidneys properly because you need a window of the fluid to be able to see. So people have infused fluid in the amniotic cavity and tried after amnio infusion to visualize the kidneys to make certain that it is actually bilateral renal agenesis. But this practice is not followed very often because it leads to chorioamnionitis and can induce preterm labor. And people have also used amnio infusion from 24 weeks of gestation onwards to avert lethal lung hypoplasia in certain individuals. There have been few case reports of almost up to 8 to 9 children who have survived with this kind of exercise. And they remarkably, they came off the ventilator, showed some pulmonary recovery, and obviously were on peritoneal dialysis right from the beginning. But it was a very turbulent kind of story, and people are not really venturing into this much. With regards to genetic counseling, if associated malformations are picked up and we can find that it's fitting into a typical syndrome, we do the genetic analysis and we counsel according to that, whether it's recessive or dominant, for the chances of recurrence in the next pregnancy. But if no extra renal malformations are found and no syndrome, etc., can be identified, it's a sporadic case, then the chances of recurrence are about 4 to 9%. Again, like unilateral renal agenesis, patients of bilateral renal agenesis also should be screened. Their family members should be screened for renal or urinary tract malformations, which may be seen in up to 15% of the individuals. Going on to the next part of my talk, which is on dysgenesis. As I mentioned earlier, dysgenesis is actually a spectrum. It has been realized that aplasia, hypoplasia, multicystic dysplasia, they represent opposite ends of a spectrum, varying only in the degree of cyst formation. Different conditions can occur in the same family. The same genetic defect can produce hypoplasia, dysplasia, etc. And also there are a number of other features which are common, like malformations of other organs, association with lower urinary tract anomalies, which I agree is more common with dysplasia, but happens in some times, some subsets of patients with even hypoplasia. And all said and done, they do follow a kind of a common course and prognosis. So most of the recent literature kind of focuses on hypodysplasia and reports it in that fashion. We, however, can, on the basis of sonography, put some semblance of order that kidneys which are small, reniform, without cysts, are usually hypoplastic. Here, the echogenicity is not totally lost, although it may be not so vividly seen as it's seen in normal kidneys. But when they are reniform with a loss of CMD, with or without cysts, they are hypodysplastic. Here again, I would like to mention that cysts are not always a must for dysplasia. When the child has associated lower urinary tract obstruction, for example, PU valve, etc., the cysts which are seen and the kidney which is seen is often referred to as cystic renal dysplasia. And here, it may be of different types. There may be multiple small subcapsular cysts, or there may be very large cysts which are almost distorting the architecture. The two varieties can be seen. And when the kidney has very large cysts, completely distorting the shape with no functioning or very minimal functioning parenchyma, it is called MCDK. So this is the entire spectrum which is seen. Going on to the, again, this is a slide which is I'm trying to highlight. This is the spectrum from hypoplastic kidneys to cystic dysplastic kidneys associated with obstruction to a multicystic dysplastic kidneys. And similarly, the histology, which, as I've discussed before, is not done very often, the biopsy. To the most vividly described form of renal dysplasia, MCDK. MCDK is a severe renal dysplasia where the kidney is replaced by dense, non-communicating macrocysts with little or no functioning parenchyma. Here, I would like to draw the attention of the audience that previously it was believed that there has to be no functional parenchyma, but recent studies have shown that some of them can have up to 15% function. Here, the renal pelvis and calyces cannot be identified, and UPJ and ureter are atretic. The incidence of MCDK is about 2,200 to 4,300 births. It is typically unilateral. Very few cases are bilateral. In one of the case reports, up to 33% being bilateral has been mentioned, but most other reports do not mention such high levels of bilaterality in MCDK. 13% males have ipsilateral or bilateral undescended testes. Abnormalities are often seen in the contralateral side, which may be 25% incidence of VUR, 3 to 5% UPJ obstruction, 2% of uretrovesical junction obstruction. In 2 to 5%, this VUR can be very severe and cause the child to progress to ESRD. 5 to 30% will have low-grade proteinuria from the contralateral kidney, and 1 to 6% may have hypertension. And what is surprising to see is most of the children who are having hypertension with MCDK have residual renal parenchymal activity on DMSA. Although we cannot rule out that the other kidney is also dysplastic, has mild degree of dysplasia, but this is what literature quotes. So MCDK etiology is embryonic disturbance of the mechanisms that generate functional nephrons linked to the renal collecting system. And a large number of patients show gene copy variations, up to in 10% of the individuals this has been seen. And in certain cohorts, certain dominant mutations in certain genes have also been studied. How do you manage MCDK? We previously had a different line of management, but most nephrologists would agree that the current management is mostly conservative. Although we realize that there is up to 25% chance of VUR in the contralateral kidneys, but we usually do not do MCU unless the contralateral kidney has abnormalities seen on sonography or scarring on DMSA, or they have a UTI. Nephrectomy, which was followed very often in the previous few decades ago, is not normally done. Only if it's a severe hypertension with residual renal parenchyma on DMSA, or a very large cystic ovary which fails to involute. Most of the patients are followed up by monitoring for somatic growth and blood pressure, by serum creatinine, urine protein creatinine ratio, serial sonography. When we are doing sonography, we are looking at both the kidneys, the ipsilateral kidney for involution and the contralateral kidney for documenting appropriate compensatory hypertrophy. The rates of involution are that 35% involute by 2 years and about 60% by 10 years. Going on to the next topic, which is of hypodysplasia. I would like to present a case of a 4-month-old female, first by birth order, born out of non-consanguineous marriage, who was admitted outside with vomiting and loose motions. She was found to have a creatinine of 1.5, which settled to 1.3 after restoring hydration. Sonography done outside was suggestive of small-sized kidneys and hence was referred to the nephrology unit. On inquiry, the baby had been born at 35 weeks of gestation with a birth weight of 1.7 kg. There was history of oligohydramnios. The baby did not require resuscitation at birth. Mother had no history of diabetes or hypertension, and there was no history of exposure to ACE, ARBs, or NSAIDs. And there was no family history of early onset renal disease and no history of recurrent fevers, etc. in the index child suggestive of prior UTI. On examination, there was no dysmorphism. Weight was 3.5 kg at 4 months. She was also wasted and stunted, normotensive. Systemic examination was normal. And USG showed kidneys of 3.1 into 1.2 centimeter by 3 into 1.1 centimeter, bilateral small-sized ecogenic with loss of CMD, no cysts. There was no hydronephrosis or hydroureter, and urinary bladder was normal. CBC showed that she was having low GFR, or creatinine of 1.7, translating into about 15 mils per minute of GFR. Hence, she was diagnosed as CKD, secondary to hypodysplastic kidneys. She underwent an ophthal and hearing evaluation, which were normal. And she was started on conservative management of CKD. What was seen was that by 1.5 years of age, her GFR had improved to 24 mils per minute by 1.73 meters square. So the question which comes to our mind is, does she warrant a genetic testing? We have heard so much about genes, CAKUT, hypodysplasia, all regulated by genes. Does she warrant a genetic testing? And why did her GFR improve if her kidneys were so small, dysplastic, hypodysplastic? How did the GFR improve at 1.5 years? And does this improvement in GFR has any prognostic implications? We'll come to that in a short while. I'm going back to the topic of renal, just a little bit of theory about renal hypodysplasia. Renal hypodysplasia is characterized by small kidneys, which basically signify the hypoplastic component, and malformed tissue elements, which signify the dysplastic component. So they are small kidneys with malformed tissue elements, primitive tubules, interstitial fibrosis, and even cartilage. On sonography, they are diagnosed by presence of small ecogenic kidneys with loss of CMD, often with cysts, but presence of cysts is not a must in dysplasia. They account for 15 to 33% of all CAKUTs if they're taken together, and almost seen 1 in 400 live births. Very often, renal hypodysplasia is associated with ectopic ureteric opening and VUR. And what is very surprising and interesting to note is the extent of dysplasia is usually proportionate to the degree of ectopia of the ureteral opening. Very often, there is associated anomalies of the lower urinary tract, obstructions like PUVs, PUJs, obstructed megaureter, urethral obstruction. The etiology of hypodysplastic kidneys, there is vascular abnormality, which may be a culprit in a certain number of cases, like we have seen renal tubular dysgenesis occurring due to renal hyperperfusion in the first trimester due to twin syndrome, or certain schools of thought think it is the abnormalities in the lower urinary tract which lead to renal hypodysplasia because of back pressure, which happens during the critical period of development. But more often, it is thought that it's a common developmental insult which is affecting both the lower urinary tract as well as the kidneys. So this hypodysplasia has also been observed in over 200 syndromes where anomalies involving other organs are present. And many are due to mutations in the genes involved in the renal tract development. The most prevalent disease-causing genes are the PAX2, HNFB1B, and SAL1. So this is just a list of a few syndromes and the genes which are associated with hypodysplasia. And all kinds of inheritance have been associated in these syndromes. So when the hypodysplasia is very severe, it may present in the antenatal period itself with oligohydramnios, just like bilateral renal agenesis. And it can be detected by antenatal sonography by following the guidelines of the kidney sizes for different gestational ages. And we document that the kidneys are not growing appropriately. And there's oligohydramnios. Unilateral hypodysplasia is difficult to diagnose. Compensatory hypertrophy may be seen, and it can be a clue. Postnatally, the presentation will depend again on the severity of renal involvement. More severe the renal involvement, earlier the presentation. the children may present in right at the neonatal age group when they are born IUGR. They may have respiratory difficulties, even pneumothorax, and or in slightly older infants when they have failure to thrive, anorexia and vomiting. And if they somehow they pass this stage of infancy, they are usually for some time asymptomatic. So older children are picked up by sonography and finding of proteinuria detected incidentally on urine routine examination. The natural course of most of the cases of hypodysplasia is there are three phases which are seen. In the first phase, which is from birth to about 6 years of age, EGFR usually improves. And in the second phase, which is from about 6 years to 10 years, maximal EGFR, which has been attained so far, remains stable. And in the third phase, which is near puberty, EGFR may deteriorate. Now, this is just a generalization which clinicians may use. We, all of us will concur that not all situations are same, but this is just a guideline. Obviously, if there are associated recurrent urinary tract infections due to VUR, there is obstructed lower system, there's hydronephrosis, or it's a solitary kidney, the progression would be more rapid. We again would agree that if proteinuria has already set in, then we can be sure that the deterioration will be very, very fast. In general, all hypodysplasia children are good candidates for renal transplant, but we always have to understand we have to evaluate the lower urinary tract prior to transplant if not done already earlier. Going on to another case, which was of a 1 year, 3-month-old male child who was born out of, first by birth order, born out of a non-consanguineous marriage. He presented at 1 year, about 15 months of age with not thriving well. He was a full-term IUGR baby with a NICU stay of 7 days. And he had had multiple admissions in the past, AGEs and UTIs. He was, dietary history was okay, but family history showed that the mother was apparently well till the index baby was conceived. And then she was noticed to have high BP during pregnancy. It was initially thought to be PIH and was managed with Depin, but subsequently she was evaluated and was found to have deranged renal functions. And sonography revealed bilateral small-sized kidneys, and she had to be started on conservative management of CKD by the time she gave birth. The index child, 15-month-old, was wasted, stunted. One odd reading of high blood pressure, otherwise PPs were normal, but he was having dysmorphism. There was convergent squint, horizontal gaze nystagmus, left undescended testes, and a sacral pit. Other systems were normal. On evaluation of the labs, he was found to have pyuria and was found to have high creatinine. His sonography at 15 months of age showed right kidney to be 4 into 1.9 and left into of 3.9 into 1.9. Slight AP diameter of the pelvis was prominent. There was about 7 and 6 millimeter respectively. Both the kidneys were echogenic with poor CMD, not lost, but poor CMD. Urinary bladder was distended with irregular walls, PVR of 13. On renal Doppler, normal renal vessels were seen. Ophthal examination showed nystagmus, and Bera was normal. So the phenotype of the child was a syndromic child with normal to reduced kidney size without cysts in CKD, secondary to a genetic disorder following autosomal dominant pattern of inheritance. So he was counseled for the need of genetic analysis, and a genetic studies was started on Sodamint and Septran in prophylactic dose. BP growth and RFT monitoring was continued and was advised detailed ophthal checkup, MCU, DMSA on follow-up. This index patient over the years What happened to him was he underwent orchidopexy at 1.5 years, did not have UTIs on Septron. His MCU showed average bladder capacity, but no VUR. Urethra was normal. DMSA showed bilateral small kidneys with decreased functioning cortex, suggestive of compromised renal parenchymal function. His mother, meanwhile, over the next few years, progressed to end-stage renal disease, was on dialysis for 2 years, underwent cadaveric transplant, but succumbed to transplant complications. This child, when last seen about 6 years of age, his BP was still normal. His creatinine had improved to 0.6, translating into a GFR of about 70 mils. Protein creatinine ratio was 0.2. And kidneys had grown in size from the previous values. Although they were hypoplastic, they were growing, but they were still less than -2 STs. There was no hydronephrosis or hydroureter, which could be seen at 6 years sonography. So this is a picture. His genetic report showed that he was having a heterozygous, likely pathogenic variant in the PAX2 gene, which is a gene very commonly associated with oligomeganephronia or renal coloboma syndrome. So renal coloboma syndrome needs a specific mention. This is because this is one of the common causes that we have encountered of primary renal hypoplasia. Otherwise, as I've said before, primary renal hypoplasia per se is not a very common entity. It is usually happening with dysplasia. It's hypodysplasia, which is seen most commonly. But this is one disorder where there is primary renal hypoplasia and it has a monogenic etiology. It is secondary to heterozygous mutations in PAX2, and autosomal dominant kind of inheritance is seen. USG show small-sized kidneys for age with poor but not lost CMD without cysts. Children are usually IUGR with poor feeding, failure to thrive, polyuria in the first 2 years. And like hypodysplasia, again, they show stable renal functions with mild proteinuria during childhood, usually remain normotensive. And they show reduced creatinine clearance by teens and reach ESRD by young adulthood. Biopsy, if done, shows oligomeganephronia, that is less number of nephrons and very large nephrons, almost 4 times the normal size without dysplasia. If done too late, it will be all sclerosis and not be meaningful. The ocular involvement in renal coloboma syndrome is variable. Coloboma of the optic nerve is the typical thing, but other kinds of involvement of the eyes may be seen. VUR is seen in about half of the cases of renal coloboma syndrome. This is again a little deviation from normal because mostly lower urinary tract obstruction is not a dominant pathophysiology in primary pulmonary hypoplasia, but this kind of pulmonary hypoplasia has VUR in almost half of the individuals. And they also have mild high frequency hearing loss, which may be seen. Another condition of primary pulmonary hypoplasia, which is very rare, extremely rare, but it is worth mentioning, is something which is called Ask-Upmark kidney. It is characterized by areas of focal hypoplasia. It was thought to be a developmental defect, but most of the literature now favors that actually it's due to pyelonephritic scarring or sequelae of focal vascular anomaly. This is usually a unilateral disease, and how children present are, they are mostly girls about 10 years of age or older who present with recurrent UTIs and with VUR seen in up to 70% of the individuals. The other presentation is with malignant hypertension, often going on to hypertensive encephalopathy or retinopathy. And when such children are subjected to sonography, small kidneys with deep scars are seen, almost slit-like. So they can be appreciated if we have the typical kind of background in mind, and we give that information to the sonologist who's looking for these malformations when he's doing sonography for such a child, or if it has been overlooked, it can be better seen with CT or MRI. Management, what is very surprising is if it's a unilateral disease, a total or partial nephrectomy is curative in such children because the hypertension is purely renin mediated. And if it can be bilateral in a few percent of individuals, if it's bilateral, it progresses to CKD. Going on briefly to another form of hypodysplasia, which can be renal tubular dysgenesis. This is a severe disorder characterized by paucity of the proximal tubules due to genetic mutations in the genes coding for renin-angiotensin system or secondary to twin transfusion. Clinical picture is very, very typical. It's either fetal demise with Porter sequence, but what is a very typical picture is that the baby is born with anuria since birth and hypotension. And this baby's antenatal scans showed normal sized kidneys, but empty bladder on sonography. Very often, such children on examination have skull ossification defects with large fontanelle and sutures. And when postnatal sonography is done, again, the kidneys either are normal sized or slightly enlarged in size. Biopsy is very typical. It shows paucity of differentiated proximal tubules, tightly packed glomeruli, and the prognosis is unsatisfactory. They progress to ESRD very fast. Very rare case report of survival up to 2 years has been documented. I would now like to talk about a form of pulmonary hypoplasia, which is very, very important and which has a lot of implications in our day-to-day life. This is the concept of subtle hypoplasia of the kidney. When we are talking about kidneys in general, we are assuming that individuals having 2 kidneys are having close to 18 to 20 lakh nephrons with them, at least at the time of birth. But what has been seen by glomerular quantification studies is that the number of nephrons in a normal population follows a Gaussian curve. There are individuals who are having nephrons which are only about 2 lakhs to those who are having 27 lakhs, which is a 13-fold change. And these individuals who are having less number of nephrons are actually suffering from hypoplasia. And they are at risk for all complications which any child with renal hypoplasia will incur. So we are witnessing a widely prevalent cause of nephropenia, which is clinically silent and deceptive, and which has implications for future kidney health in adults and even children. So how do we recognize this subtle renal hypoplasia? I would be coming to that in next few slides. First, the recognition as to which of these individuals we have, after this quantification, we tried to find out as to what are the factors which may be responsible for these individuals having less number of nephrons. And amongst the factors which have been definitely proven has been premature birth, IUGR, maternal vitamin A deficiency, and polymorphisms in genes which are associated with severe renal hypoplasia. Now, with regards to prematurity, we all have already seen multiple times that nephrogenesis stops at 36 weeks and is most active between 20 to 36 weeks. So if baby is up and 60% of nephrogenesis happens after 28 weeks. So preterm babies do not undergo normal intrauterine nephrogenesis. It's not that nephrogenesis stops when they're born. It does happen after birth too, but it is not proper and it is insufficient to make up for the nephron deficit. So all preterm babies are actually at risk of poor nephron endowment and at risk for subsequent CKD and hypertension in adult life. IUGR babies. It has been seen in autopsy studies that infants who are born with growth restriction have fewer nephron numbers. And it has also been quantified that 1 kg weight gain in IUGR babies is associated with almost 2 lakh nephrons, which are extra. Maternal vitamin A deficiency, it has been again proven in women who are having vitamin A deficiency. They give birth to children who are having less number of nephrons than the ones who are vitamin A replete. This was demonstrated in a cohort of Indian women vis-a-vis women from Montreal, and Indian women who were having low retinol levels gave birth to children who were having 62% of the kidney size vis-a-vis their Montreal counterparts. Now, even more data is coming. Even maternal malnutrition, smoking, gestational hyperglycemia, chronic infections, illnesses, etc. in the mother have been implicated to play a role in the number of nephrons that a person has at birth. And even demographic factors are at play. We know that taller individuals are having more nephrons than the shorter ones. Females have about 10% less nephrons than the males. And a certain kind of ethnic groups like the Australian Aboriginals, etc., and Japanese, they are having less nephrons at birth than some other races. So the typical renal hypoplasia genes, which we talked about in the topic of renal hypoplasia, where we documented loss of function mutations in those genes, they cause hypoplasia. The same genes, it has been seen that if there are milder mutations or mere polymorphisms in many of these genes, individuals having such polymorphisms have less number of nephrons than some others. So the implications of this problems are many. We have seen that there is an inverse relationship between nephron number and hypertension in multiple studies. Hypertension is seen in 15% people having more than 10 lakh nephrons, 33% in those having 7 lakh to 10 lakh, and 100% in those having less than, 7 lakh glomeruli. Nephronopenia is associated with increased risk of CKD. And not only hypertension and risk of CKD, these individuals having less nephron endowment can have very serious consequences when they encounter other renal illnesses during the lifespan, like IgA nephropathy, or even apparently innocuous renal conditions like MCNS. They can have very ominous outcome. Even diabetics, studies have shown that diabetics having polymorphisms in PAX2, they have lower GFR than the controls. So in a country like India and in other developing countries with rampant maternal malnutrition, in more than 1/3 of the pregnancies complicated by prematurity and IUGR, there are a lot of implications for this kind of subtle renal hypoplasia. Now, what can be done? One is that traditional measures are used. We assume that all preterms, all IUGRs, and certain ethnic groups, they are at risk for CKD and hypertension. We serially monitor these at-risk patients with kidney sizes on sonography, BP, creatinine, proteinuria. But all this CKD and hypertension will happen in many years. And the traditional measures on sonography of renal length and the breadth, etc., will not be able to pick up these individuals with less nephron endowment. So that leaves you with other kind of measures like nephron quantification studies, which are actually just a research tool, or doing a biopsy, which is actually very invasive. How many biopsies will you do when the numbers are so large? So that too is actually not the answer. Theoretically, prenatal sonography can pick up if it's a unilateral condition, but this also is not applicable. So there's a novel measure which can be used and which has been studied to pick up these individuals with less nephron endowment, and that is measuring the TKV or total kidney volumes in high-risk individuals. Now, TKV can be measured by MRI or by sonography. Additionally, such individuals can also be subjected to more accurate form of GFR measurements using cystatin C-based equations. What is this?
In between, ma'am? Actually, we are running short of time.
Ma'am, last two slides.
Sure.
Slides.
Yeah.
Use
we
of
have
TKV.
Polling sessions also. Yeah.
Use of TKV by for measuring nephron endowment. Now, patients with low nephron endowment have smaller kidneys, which are not detectable by usual USG measurements. TKV normalized to body surface area is a surrogate marker of poor nephron endowment. It can be measured either by MRI, and this is done very often in AD-PKD patients. They are monitored with TKV measurements, or it can also be measured with USG if we use 3D measurements of length, width, and depth using ellipsoid formula, or even 2D sonography, which is done very often, but using the calculations, although accuracy is a little less. And what is normal and what is abnormal? They are normative tables which have been, which are available, which are being formed. They have been made on children who are from 1 month of age to 18 years of age, which actually depict the TKV to the body surface area ratio. And it has been seen that this too has a normal Gaussian kind of distribution with the mean at about 132 ml per meter square. Individuals who are having their TKV by BSA, which is less than the 10th percentile or less than 90 mils per meter square, are at high risk of CKD. And these are the ones who can be more vigorously monitored, and the more accurate measures of GFR, etc., can be done in them. The last slide, the carry home which we can take from the presentation is that patients with agenetic, dysgenetic kidneys have high likelihood of urinary tract malformations and malformations of other organs. In familial and syndromic cases, molecular testing must be done after making an attempt to reach a specific diagnosis on the basis of phenotype. Family members of patients with renal agenesis, dysgenesis must undergo ultrasound to detect renal and urinary tract malformations, because almost 15% of them are likely to be having this, may not know about it. Unilateral malformations, previously thought to be innocuous, also need to be monitored because they may have subtle hypoplasia dysplasia in the other organ, or have poor outcome related to the lower urinary tract malformations which may be associated. Oligonephronia is a newly recognized entity that has long-term implications in terms of development of hypertension and CKD in future. And TKV by sonography may be used as a surrogate marker of oligonephronia in future and hopefully help mankind. Thank you.
Thank you, Alpana ma'am, for such a lucid and comprehensive presentation on renal dysgenesis and agenesis. You have simplified a complex topic with your excellent deliberation. Thank you for your presence today here. We shall now be going over to the questions, right, Dr. Kalaivani? Can we take up the questions now? Yeah. So we have the first question is for Dr. Zubeda. One viewer wants to ask, how frequently should we follow up the cases of fusion anomalies of kidneys, and what are the genes which could be responsible for fusion anomalies or CAKUT? That is the first question.
Okay, thank you. So how frequently we followed up, actually it depends on the renal fusion anomaly with its associated condition. Like if the patient having some associated condition like BUR or ureteropelvic junction obstruction, they may have some UTI, then other abnormalities, and this patient should be in regular follow-up. If there is a repeated UTI, there can be formation of renal scar and so on. But the patient, if have isolated renal fusion anomalies, and it's like there is no associated condition or associated other systemic involvement, so every yearly or 2 yearly, we should keep them in follow-up. And with the following with the case with their routine urine examination, then serum creatinine, renal growth, and hypertension, we should monitor. So in the second question, there is any association with genes. Yeah, there is a important genetic factors are related to this CAKUT. So, but in compared to the renal dysplasia or hypoplasia, infusion anomaly, it's not so common or less common, I would say better. So when there is, we found that in horseshoe-shaped kidney, there are some genetic abnormalities like Turner syndrome, Down syndrome, Edward and Patau syndrome, all can be associated with horseshoe-shaped kidney. So can we go to the next question, or anyone can add? Dr. Amrish is there, Dr. Ramalvar sir is there. If anything they can add.
I don't have.
No, I agree. I think you're very right.
So I can see the next question. So this is, I just read the question. What is the cause of CKD in horseshoe kidney? Okay, so yeah, we found in the some articles that the horseshoe kidney patients are developing end-stage renal disease and CKD, like CKD and end-stage renal disease. So it's also depends on the associated condition. Like if there is the repeated UTI, scar can form in the kidneys, and if sometimes the horseshoe kidney are present solitary, like only horseshoe kidneys, like fused isthmus is there, but no other associated urogenital anomaly. So in those cases also, there are chance of developing renal urinary tract infection due to the there is a the ureter are have high union with the renal pelvis, so they may have chance of renal UTI, and also renal stone can form in these cases, in solitary cases also, like there are some stasis, then infection, then some metabolic anomalies. And horseshoe-shaped kidney also have chance of carcinoma. Renal cell carcinoma is most common. It's if we go again in the theories for the renal fusion anomaly, we saw that some teratogenic effects are there, and mostly on the parenchymal mesenchyme. So I think if these are the causes, without any other anomalies of the urogenital tract, in solitary kidney also, if the renal stone formation and renal carcinoma, it obviously it will deteriorate the renal function, and gradually they can develop CKD and finally end-stage renal disease. Anything else? Yeah.
We can move on to the next question. That is again, what is the difference between pancake kidney and
crossed renal ectopia? Yeah, I have already mentioned that pancake kidneys are fused in the medial line, in the superior, inferior, and like in the midline they are fused, but there is no crossing of the ureter. Like ureter are in their same orthotopical position. So, but in crossed renal ectopy, though the kidneys are going opposite side, and they are fused in wide axis, or usually in the medial axis, but their ureters, like ectopic kidneys, ureters again goes opposite side. It's in its orthotopical normal side. So this is the most main difference between pancake kidney and the crossed renal ectopy. If I can share the pictures. Anyway, the time is short. We can move on the next question.
Yeah, so the next question is, what are the investigations to be done when we detect a simple ectopic kidney in the ultrasound in an asymptomatic patient?
Yeah, most of the cases, fusion anomalies are asymptomatic. When they come to us, it's just incidentally with the incidental findings. So in a simple renal ectopic case, we know that they are associated, most common is the viewer. So if the initial ultrasonogram is normal, like there is no ureteric dilatation, the renal size is okay, CMD is maintained. So I will suggest that the baseline creatinine, urine routine examination, and ultrasonogram should be in, we should keep in our data, and we will follow up the case every 1 or 2 yearly and check the renal growth, if there is any hypertension or any symptoms of UTI. We'll follow up in that way. No more, no other investigation is needed, like to detect VUR or like CT scan. I don't think these are needed in a simple ectopic cases if all the there is no other anomalies in the ultrasonogram.
Right. Thank you, Dr. Zubeda. Can we move on to the next question? The next question is for Alpana ma'am. This question asks, what are the differences between agenesis and dysgenesis?
As I mentioned in my talk that I gave, agenesis basically refers to the kidneys not being formed at all, or aplasia, and dysgenesis refers to maldevelopment of the kidneys in terms of size, shape, or structure, and includes both hypoplasia and dysplasia.
Right. And again, an extension to the same question, which one may be more complicated, agenesis versus dysgenesis?
So obviously, unilateral, either of the thing would be unilateral or bilateral. If it's bilateral renal agenesis, we know it has to be 100% demise, either in the fetal life itself or in the newborn period, unless a transplant, etc., is undertaken. So very few survivors of bilateral renal agenesis have been there. So it's uniformly fatal. With regards to unilateral renal agenesis, they have a comfortable life till about 30 years of age. Then about 30% can develop into ESRD. We have talked about that. With regards to hypoplasia, dysplasia, again, it depends upon whether it is unilateral or bilateral, and the severity again can vary. But obviously, if we are going to the usual scenario, they may have a lifespan of about 10 to 20 years. So obviously, if you have to choose between the two, you would choose hypoplasia, dysplasia than aplasia or agenesis.
Yeah. Thank you, ma'am. Again, the next question you have covered in your talk, they want to know the syndromes which are associated with agenesis and dysgenesis.
For this, they'll have to refer to the books because there are over multiple syndromes. It's not really possible to enumerate all of them. So various kind of syndromes have been described. Some which in genes have been culprit genes have been identified. And which are showing a autosomal recessive dominant kind of inheritance. And some of them are syndromes where even there's no cause which have been found. They're just associations which are being studied and found in patients. So for that, they'll have to go back to the books. There are hundreds of syndromes. With regards to how diabetes causes renal agenesis. See, when we come across such individuals, we do not carry on studies to study the cause and the effect of a particular thing. It is a thing which has been studied in population of children who are having renal agenesis. Their mothers were studied and were studied to find out the high risk situations. And it was found that the ones who were having diabetes mellitus were more likely to have. The exact pathophysiology, etc., has not been worked out, but this is an association which has been studied by epidemiological studies. Okay, what is the rate of malignancy in MCDK? So MCDKs are known to have a risk of Wilms tumor. It's about 3.5 cases per 1,000 population, according to the literature which is available. So it's not actually a very high risk, but still it is, we are anyway looking at the kidneys of MCDK children to look for involution, we do have to keep it in mind. But the risk, according to literature, is only about 3.5 cases per 1,000 MCDKs on follow-up.
Yeah, thank you, ma'am. The next question is, will you do DMSA for MCDK for all cases, in all cases of MCDK?
DMSA should be done in all patients with the MCDK. One is, we have to know the status of the other kidney. As I had put in my presentation, 25% of these children are likely to have contralateral reflux. And if we find any abnormality in the other kidney on DMSA, our decision of MCU is totally weighing on that. The other is DMSA will tell you if there is a residual function present or not. Most often there is no residual function, but if there is residual function and the child has hypertension, then there is a mild scope of doing nephrectomy to resolve that hypertension if the patient doesn't want to take antihypertensives. So going by all this, we just have to do a DMSA scan in MCD.
Yeah, again, the next question, differences between MCDK and polycystic kidney disease, PCKD.
Polycystic kidney disease and MCDK. Okay. So see, polycystic kidney diseases are actually, by definition, it refers to AD-PKD and AR-PKD, which are monogenic disorders having dominant and recessive inheritance respectively, vis-a-vis MCDK, which is a developmental aberration, which may not be having a pure genetic basis. MCDK is most of the times unilateral. PCKDs, polycystic kidney diseases, are bilateral conditions, and the recessive ones, AR-PKD, progress to ESRD by about 15 to 20 years of age, and AD-PKD from 50 to 70 years of age. MCDKs are usually unilateral. They may run into problems in adulthood of proteinuria and hypertension and mild renal dysfunction, but usually unilateral MCDKs have a normal lifespan. Just an adulthood, few of them may run into problems, but mostly unilateral MCDKs are having a normal lifespan.
Again, now there's an interesting question. Does acquired single kidney versus congenital single kidney carry the same prognosis? Again, for Alpana, ma'am.
Tell me the question again.
Does acquired single kidney versus congenital single kidney carry the same prognosis? Acquired as in maybe a transplanted kidney or a donor kidney with a single kidney versus the prognosis for a congenital single kidney.
See, there are multiple ways to look at this question. One is that right from the birth, we had a single kidney, and here, when the patient has one unilateral renal agenesis, as I said, there is a possibility of anomalies, 30 to 70% chances of anomalies in the other organs as well. And sometimes even the other kidney, contralateral kidney, is also mildly dysplastic. So it depends upon whether he's having those associated malformations or not, and what is the status of the other apparently healthy kidney. It's apparently healthy, but it may be having areas of focal dysplasia, etc. The same thing which has severely affected one kidney may be actually affecting mildly the other kidneys. This is in comparison to another individual who is not having these associations, is just, I assume, a live-related donor who has undergone a donor nephrectomy and so on. This individual, we have to again understand, with age, some of our nephrons are dying at all times. So that risk of less nephron number, depending upon the age of the individual, that risk remains. So it depends upon the associations, but probably the congenital ones would have more problems than the acquired ones. But if acquired are having diabetes, hypertension, they are aged, or other things, then it's hard to answer.
One more question we can take, a few more. Is kidney biopsy warranted in patients suspected of dysplasia due to elevated creatinine but borderline sized kidneys? Is a biopsy warranted in such patients?
See, kidney biopsy warranted in individuals who are having borderline sized kidneys and
Elevated creatinine and suspected of having dysplasia.
okay. So usually, if you are having a child who's having bilateral small sized kidneys, slightly elevated creatinine, you would think of dysplasia only if they are not having proteinuria or any other nephrotic feature. So they are otherwise a bland urine and still it is showing dysplasia. You are suspecting dysplasia, then maybe not. But usually what happens is it all depends upon the entire clinical picture. There have been instances where there was proteinuria, high creatinine, smallish kidney sizes. When we were thinking of glomerular strongly, we do. But if we are strongly suspecting it's dysplasia, the completely bland urine, and there are syndromic features which suggest that it may be a part of a syndrome, dysplasia, etc., then we can get away without having to do it. Because we would have genetics at our disposal, which is a safe and a definitive test rather than an invasive procedure in a child at risk of bleeding diastasis because of azotemia.
Dr. Arpita, can we stop with the questions and move ahead to the polling session because it's already 8:30? And almost all the questions, no, it's been covered in the talk. Probably the participants can look at the recordings.
Sure. So
Is it all right, Dr. Alpana? Like,
yeah, ma'am.
Yes, ma'am. No problem.
So we can end our session here for today and go over to the polling station. Before that, I would ask respected Namalwar sir for his final comments. Sir, is he here?
no, sir just left, I guess.
Amrish sir probably could take this.
Yeah, no, this was an excellent session. We had two great speakers and two great topics which were covered in great details. So again, thank you to both Dr. Zubaida and Dr. Alpana for excellent talks. We really appreciate your time and all the details that you shared with us. And thank you, Dr. Arpita, for excellent moderation. We can see that, this was such a well-attended session and all the great discussion was there. Thank you once again, everybody, for joining. And if you would like to stay back for the polling session, please do. Otherwise, you can leave. Again, thank you so much for your time.
Thank you, sir.
Thank you, Dr. Alpana. You made the complex topic very interesting with case scenarios.
Thank you.
Thank you, Veda. Thank you so much. So we'll move on to the polling session now. So totally the polling session question is going to be 10 and we'll have total 6 minutes for the polling session. I think it is the same instruction. We have total 10 questions and 3 are considered to be star questions. So we'll start with the poll now. Last 1 minute. So we are closing the polling session. Thank you all. Thank you for participating. Thank you, Dr. Amrish. Bye-bye.
Thank you. Bye-bye.
Bye-bye. Thank you, Dr. Arpita. Bye-bye. Thank you, Dr. Uma.
Thank you, Dr. Uma. Thank you, Dr. Arpita. Bye-bye.
Thank you so much, all of you. Thank you.